restricting the filling of the ventricles, and restriction is the patient has internal restrictions or internal limitations in the LV filling. So to understand these two conditions and to differentiate amongst them, we have to understand the normal cardiac hemodynamics. So I'll just brief about the normal cardiac hemodynamics here. Diastole and systole are closely linked to one another, with the preload is provided by diastolic filling, which is necessary to generate the stroke volume. Now diastolic filling, it depends on many factors. Some of the factors are extrinsic to the cardiac chambers and other factors have intrinsic myocardial properties. So the factors which are extrinsic to cardiac chambers, which include the pericardial restraint, the chest geometry, and the loading conditions which is imposed upon the heart. And the intrinsic myocardial properties includes the viscoelastic forces, the myocardial stiffness, and the stress-strain relationship. So if you see ventricular diastole, so it's broadly divided into three components, that is the early rapid filling, a late diastolic filling, and the last phase of atrial contraction. So the early rapid filling, the components or the sequence of events which this occurs, and the factors which are responsible for early rapid filling includes the early ventricular relaxation phase, and this causes a driving pressure across the mitral valve, and that causes the blood to be shifting from LA to LV. In the late diastolic filling, there is continued LV relaxation. Along with that, the pericardial restraint here comes and acts. So the pericardial restraint is a factor which is influencing your late diastolic filling more rather than the early rapid filling, and the final phase is of atrial contraction. So in both of these conditions, the diastolic dysfunction is the hallmark. There is elevated ventricular filling pressures and the mean atrial pressures are elevated. And in constrictive pericarditis, the early rapid phase is preserved, that because the myocardium is relaxing very properly, and the pericardial restraint part, as I had mentioned, it presents in the late diastole. So the early rapid phase is preserved in constrictive pericarditis, whereas in restrictive cardiomyopathy it is a pan-diastolic impairment, because the muscle the muscle itself is abnormal, so it doesn't relaxes properly. So if you see this diagram, it is very nicely explained in this diagram how the diastole phase of the cardiac cycle acts, and there is a ventricular pressures and atrial pressures which are seen, and the mitral valve flow signals are seen as well. So after the systole is completed, there is a phase of isovolumic relaxation time, and here the ventricle relaxes, the atrial and the aortic and the mitral valve are closed, and the ventricular pressure falls. Now as the atrial and the ventricular atrial pressure rises and the ventricular pressure falls, the cutoff point where the mitral valve opens, and that's where the rapid filling phase occurs. And then there is a phase of equalization of LA and LV, and then there is a final phase of atrial contraction where the LA pressure increases and the final emptying of LA happens. So the early rapid filling is responsible for 70 to 80% of the LV filling, and then there is a phase of diastasis, and finally then there is a atrial contraction. So if you see the Doppler flow across the mitral valve, the E wave is what is the early rapid filling, and then there is a phase of diastasis, and then finally you will get the A wave. If you see the LV and RV sided filling pressures, they are equal in constrictive pericarditis, whereas you will find some amount of difference in the restrictive cardiomyopathy. The filling pressures are very high in restrictive cardiomyopathy, whereas they are not that high in constrictive cardiomyopathy, constrictive pericarditis. The pulmonary artery systolic pressure, if it's more than 60, it favors RCMP. A pulmonary venous flow, the systolic flow is blunted and the diastolic flow is increased in RCMP, that's in restrictive cardiomyopathy, but there is normal systolic and diastolic flow of pulmonary venous flow in the constrictive pericarditis. The hepatic veins, they show a expiratory flow reversal with constrictive pericarditis, whereas they show an increased inspiratory respiratory flow reversal is what is seen in restrictive cardiomyopathy. The square root sign is present in both, but it's more predominant in constrictive pericarditis. Now if you see the Doppler differences in between them, the mitral Doppler inflow patterns in both CP and RCMP are early diastolic wave, that is the E wave, is prominent with a short deceleration time. It reflects predominantly early rapid filling. A very critical difference is the absence of respiratory variation in restrictive cardiomyopathy. Mitral inflow in CP, it demonstrates a respiratory variation of more than 25% with increased in velocities during expiration, that is the left sided filling happens more with expiration, and the mitral E wave deceleration time is decreased and is less than 160 milliseconds. The lack of respiratory variation should not exclude the diagnosis of constrictive pericarditis. Now this will see the pattern of inflow. If you see, and if you find more than 25% variation in these Doppler signals during inspiration and expiration, and that does confirm or favors the diagnosis of constrictive pericarditis. Of all the echographic parameters, the most important or the most useful is the mitral annular tissue Doppler assessment. The early medial mitral annular tissue Doppler E' velocities are normal or often paradoxically increased in constrictive pericarditis, and that is known as annulus paradoxus. So if you see that sometimes the mitral medial annular velocities are increased in constrictive pericarditis, whereas the tethering of the lateral LV free wall can result in a reverse relationship between the medial and the lateral mitral annular Doppler velocities. That is, the lateral cardiac motion is limited in constrictive pericarditis, and therefore here you will have the medial E' higher than the lateral E', and this is known as annulus reversus. Normally it's the opposite, is what's seen. Now in restrictive cardiomyopathy, there is a decreased E', there is a mitral wall tissue Doppler velocities are reduced throughout. One more finding which we will see in restrictive cardiomyopathy is apical. When you see the apical 4-chamber view and a 2-dimensional echocardiography, it reveals this characteristic biatrial enlargement, which is also seen like an owl appearance. And if you see something like this in a 2D echocardiography, it's more suggestive of RCMP. So to again summarize, there is a respiratory variation which is exaggerated in CP and not in RCMP. Then there is a ventricular wall thickness is usually increased in RCMP. The pericardial thickness of more than 3 to 4 millimeters can be seen in constrictive pericarditis. The atrial size, as I have already mentioned, biatrial enlargement classically in RCMP. The septal bounce, which is very important, is a good sign which will be seen during inspiration and expiration. As I already mentioned, the mechanism which may be present in 2D echocardiography in CP and won't be seen in RCMP. The Doppler E' velocity is increased, the medial, especially the medial one in CP, and they are reduced throughout in RCMP. And if you see the systolic area index, it's greater than 1.1 in CP and it's always less than 1.1 in RCMP. So I'll end the talk with a simple X-ray which sometimes gives a clue or a diagnosis of constrictive pericarditis, where you can see the calcified pericardium. It's very apparent here in both PA and the lateral views. You can see the thin rim of calcium, and it helps us to confirm the diagnosis of constrictive pericarditis. Thank you very much.